that more precisely define the type of personality impairment that an individual had and could help direct the kind of treatment they ought to get. But our Board of Trustees was not ready to go there. And if you think we have problems with an external review process, think of the ICD. It has 193 countries that have to get agreement from the World Health Assembly of any changes that take place there. So our scientific classifications are subject to political assessments as well. And so that's the kind of thing that, that you have to deal with when you're doing a major classification change like this. Any other questions at this point?
May I have another question, please? I wonder, being a DSM writer, and how the group of writers change the criteria of diagnosis. Is it according to researches or just opinions? And to change the criteria, time criteria, inclusion criteria, and symptom criteria, I mean, how you finalize the things that is applicable to the whole world? I mean, you have a divergent biopsychosocial model, and it is difficult for me to understand that issue.
Okay, so sometimes you can do it on the basis of wonderful data. The decision about how you would do, for example, with the substance use disorder criteria, there were more than 200 studies and 200,000, patients or subjects involved in epidemiologic and clinical studies to show that abuse and dependence were not separate disorders, that they were on a spectrum, and that for the 11 criteria, once you dropped the legal criteria and added the craving, you still had 11. Okay, so it was possible to do very careful quantitative assessment that if you maintain the same prevalence rate, okay, that 2 or more of the 11 criteria was your threshold for mild clinical substance use disorder. Now, what that did is interesting. It required only 1 of 4 to meet abuse criteria, but it required 3 of 7 to meet dependence criteria. So there was an orphan group. What if you had 2 of the 7 and none of the abuse criteria? You didn't qualify for anything, okay? So what was interesting, that we could show that those folks, were impaired, even though they didn't even meet criteria, because you had all kinds of correlates with it. So for the substance use disorder area, it was possible to be very explicit. Likewise, for attention deficit disorder, when we made a decision to go with 5 out of 9 criteria for either attentional deficits or hyperactivity or impulsivity criteria, we did this on the basis of an enormous database that showed that actually we would meet the threshold for adult ADHD better if we made it 4 out of 9 instead of 5 out of 9 or 6 out of 9. But there was real concern that we would have criteria that were too sensitive and not specific enough, that it would pull in all of the people who had the disorder, but it would pull in some people who were normal. And so on the basis of the evidence, we made a decision that it would be 5 out of 9 for adults, 6 out of 9, for kids. So again, that was very empirically based. Now, for some disorders, though, the original decision, for example, of 5 out of 9 criteria for major depressive illness, how was that come to? It's been there in many ways before DSM-5, and it was kind of an estimate based on Hamilton, who did the Hamilton scale and so forth, that seemed about right, and it was about that level of evidence, that it was a clinical judgment, that was but again, oftentimes some of those judgments were made on the basis of clinical judgment and on the basis of inpatient care clients, as opposed to community, epidemiological samples or primary care samples. So it is, until you have, hemoglobin A1C, equivalents for defining major depression, you're going to be left with phenomenological symptom syndrome type of definitions and of making judgments about where that threshold is. What we would like to be moving toward is better pathophysiology markers and also better markers from phenomenology of symptom clusters, syndromes that better predict treatment, response, and clinical course. And clinical utility is the major criterion that we try to apply in assessing thresholds and the like at this point. But it's an inexact science at this point in time, and it simply is the status of our field at this point. Just a few minutes? Okay. 15 minutes. Okay, well, I can cover a lot in 15 minutes. So, a major thing that we tried to introduce in the DSM-5, and you really will see this in the large book and not so much in the small monograph that you have. We thought that DSM could benefit from having explicit criteria for both categories and dimensions, not either or. And so for any specific psychiatric disorder, a number of aspects could be conceptualized and assessed dimensionally, and we wanted to have a way of looking at cross-cutting dimensions in DSM that could help for research as well as practice. And WHO was also concerned about what would the rest of the world think if we moved to a more dimensional approach? And they had this international survey and of clinicians, and asked, now the question is it going to sync up with the computer without having to restart the computer? If this one had a pointer, I wouldn't have to mess around with two. And I thought it had a pointer, but it's, okay, let me finish this here. Okay, so what the WHO said is, should a diagnostic system incorporate a dimensional component where some disorders are rated on a scale rather than just as present or absent? 12% said yes for more detailed and personalized diagnoses. 43% yes, more accurate reflection of psychopathology. So right here you have 55% said that there ought to be a more dimensional approach to diagnosis. This is a worldwide kind of effort. 20% said no, it's too complicated in clinical settings, and no, insufficient research reliability. So you get a sense of what the differences of opinion were about moving to a more dimensional approach. But we thought that it would be certainly relevant for prognosis, treatment planning, and outcome. And so we developed both a level 1 and level 2 cross-cutting symptom assessments, and we added some diagnostic specific severity ratings, and also a disability assessment into the DSM-5. And the cross-cutting level 1 are 13 different symptom domains for adults and 12 symptom domains for children, 11 plus for parents of children, for those who are age 6 and greater. And these are 1 to 3 questions per symptom domain, and they screen for important symptoms, not for specific diagnoses. So we talk about them as cross-cutting. And if somebody gets a mild or greater in the level 1, we had a iPad kind of application of these level 1, level 2 symptoms for our field trials, so that if you got a mild on the level 1, you'd automatically be kicked into the level 2 on the iPad, and you would get a more detailed assessment of the symptom domain. And these level 2 are based on pre-existing well-validated measures, including some of the inattention scales for kids, NIDA modified assist measure for substance use, and these promise forms, which are patient-reported outcome measurement information system, like for anger, sleep disturbance, emotional distress, that the NIH has been developing for all outcome measures for all medical conditions. This is the NIH symptom-based outcome measures, looking at patient-reported outcome measurement information system. And they have things like sleep and anger and depression and anxiety and cognition and substance use that they are trying to have clinicians in primary care practice settings use to assess patients at the beginning and during treatment and at the end of treatment to measure their assessments for all kinds of chronic diseases. So for documenting the severity of a specific disorder, the frequency and intensity of its component symptoms are important, not just do they meet or not meet the criteria. And if a diagnosis meets full criteria, we want to make sure that we know where they are on the thresholds of severity for a given disorder as well. And the most common severity measure is this Patient Health Questionnaire 9, the PHQ-9, that I mentioned to you before. And we recommend this for looking at severity of major depression. And if you get like a score of, for the 9 different criteria of major depression, if you get nearly every day for all of these, you can get up to 27. So generally, if somebody has up to 10 symptoms, it's mild, 10 to 14, it's moderate, 15 to 20 is a score of moderately severe, and 20 and over is severe. And this is often used as an outcome measure in clinical settings. And then for disability, we are strongly recommending the WHO Disability Assessment Schedule that we helped to develop at the NIH for over a decade. This is, it corresponds to the disability domains of the International Classification of Functioning, developed for use in all clinical and general population groups, tested worldwide and in our DSM5 field trials, includes 36 questions self-administered with clinician review, and we've also have an adult or a child version that we've developed. And the WHO domains include understanding and communicating, getting around, self-care, getting along with people, life activities, and participation in society. And this is really much different than the GAF, the Axis 5 in the DSM-4, which is a confounded combination of symptoms and functional disability. And in the US, oftentimes you would need to have like a score of 40 or less in order to get a patient admitted to the hospital, and you'd have to have them have a score of 60 or greater in order to discharge them. And so it was a system that would be easy to game, so to speak, and was not reliable. And so what we're trying to get is 3 different assessments. One of severity of symptoms, a second of kind of suicidal risk, which is also a part of the GAF, and a third of disability. And for disability, you know, the HUDAS is a separate measure of disability. And our Social Security Administration and certainly Veterans Administration is all evaluating the degree to which they can move to this kind of a disability assessment for their major disability measure. And we wanted to have the same disability measure for psychiatric disorders as is used for the rest of medicine. So when you're doing global burden of disease estimates, you're using the same metric for determining disability or disability adjusted life years and measures of that type. So that's the background for why we moved to this. So you can access in the print version the level 1 cross-cutting adult and parent measures, the psychosis severity measure, and adult disability. And online you can just pull down for free, go to our website, all level 1 and level 2 cross-cutting measures, all disorder severity measures, and the adult disability measure. And you can go online to this www.psychiatry.org/DSM5 in order to find those measures as well. And I think that's where we will stop for right now. Thank you.
Thank you, Professor Darrel, for your kind speech and presentation. We will stop here and we will go to Jum'ah prayer. It's an self-service. I mean, there is no a bus for that. Use your own vehicle, and we will reunite after that to take our lunch, and we will resume the session, inshallah, at 2 p.m. exactly, inshallah.